Hi, today I'll be talking about sodium disorders which include hyponatremia and hypernatremia. Hyponatremia is defined as sodium less than 135 milliequivalents per liter. It's the most common electrolyte disorder seen in hospitalized patients, accounting for 15 to 25%. It is associated with hypoosmolality, which is defined as less than 280 milliosmolar per kg. Most cases of hyponatremia are due to elevated arginine vasopressin, which is also called antidiuretic hormone, resulting in water retention. There is an excess of body water related to sodium content, contributing to hyponatremia. Assessment of volume status, the degree of hyponatremia, acuity of onset, severity of symptoms is very important. Acute hyponatremia is defined as onset less than 48 hours, and it can cause significant morbidity and mortality due to osmotically induced brain edema. On the other hand, chronic hyponatremia is defined as onset greater than 48 hours, and it can result in severe neurological deficits if it is rapidly corrected. Hyponatremia in general is associated with worse clinical outcomes across the entire range of inpatient care, from medical floor to ICU patients. Hyponatremia can increase risk of falls from gait instability. Severe hyponatremia is classified as sodium less than 125 milliequivalents per liter, and it is associated with twice the mortality. Inappropriate diagnosis of hyponatremia leads to wrong treatment and bad outcomes. Fusion. Most common symptoms of hyponatremia are usually associated with central nervous system, which can be altered mental status, confusion to lethargy, and coma. Some of the CNS complications can include seizures and permanent brain damage. Non-CNS symptoms include nausea, vomiting, cramps, and weakness. Classification of hyponatremia by plasma tonicity or osmolality. If the plasma osmolality is less than 280 milliosmol per kg, then it's known as hypoosmolar or hypotonic hyponatremia. If the plasma osmolality is normal between 280 to 295 milliosmol per kg, it's called isosmolar. And if the osmolality is greater than 295 milliosmol per kg, then it's called hyperosmolar or hyper. Some of the labs needed for assessment of hyponatremia. Serum osmolality can be calculated either by measured serum osmolality, which we can obtain by labs, or we can do a calculated serum osmolality by the formula 2 times serum sodium concentration plus serum glucose concentration divided by 18 plus blood urea nitrogen divided by 2.8. Now the difference between measured and calculated osmolality results in osmolar gap. Increased serum lipids or proteins do not affect the measured serum osmolality. Urine osmolality is of less clinical significance than serum osmolality. It's usually reported as a range between 50 to 1200 milliosmol per kg. The appropriate response to hyponatremia is to produce a diluted urine. However, this is not seen in most of the cases except for psychogenic polydipsia, where the urine osmolality is less than 100 milliosmol per kg. Other labs to check are urine sodium. If the urine sodium is less than 20 milligrams per liter, it usually reflects hypovolemic or hypervolemic hyponatremia, whereas urine sodium between 20 milligrams to 40 milligrams per liter usually reflects euvolemic hyponatremia. Plasma glucose is mandatory in all cases of hyponatremia, and serum sodium usually decreases between 1.5 to 2.5 milligrams per liter for every 100 milligrams per deciliter of increase in glucose. Tests for thyroid functions such as TSH, free T4 are important for diagnosis of hypothyroidism. One should check ACTH and free cortisol level for assessing the adrenal function. Evaluation of hyponatremia. If the serum sodium is less than 135 milliequivalents per liter, and if the patient is asymptomatic or has mild symptoms, one should determine the serum osmolality. If the osmolality is normal between 280 to 295 milliosmol per kg, then it's classified as isoosmolar hyponatremia. For this is pseudohyponatremia. The most important causes are hyperlipidemia and hyperproteinemia such as multiple myeloma. If the serum osmolality is low, less than 280 milliosmol per kg, which is the most common finding of hyponatremia, it is classified as hypoosmolar. If the serum osmolality is greater than 295 milliosmol per kg, then it's called hyperosmolar. One should assess the volume status at that time. If the volume status is low, it is classified as hypovolemic hyponatremia. And if the urine sodium is greater than 20 milligrams per liter, the most common cause could be renal loss from diuretics. If the urine sodium is less than 20 milligrams per liter, the hyponatremia is most related to extrarenal loss from GI loss such as vomiting, diarrhea. Now, if the patient is euvolemic, one should check the urine sodium, and if it's greater than 20 milligrams per liter, one should check the urine osmolality. If it's less than 100 milliosmolar per kg, then it probably is from primary polydipsia. It can also be from a condition called Beer-Potamania syndrome. If the urine osmolality is more than 100 milliosmol per kg, most likely it is from syndrome of inappropriate antidiuretic hormone, also called as SIADH. If the extracellular fluid volume increases, called hypervolemic hyponatremia. And if the urine sodium is less than 20 millicoulomb per liter, the most common causes are heart failure, cirrhosis, and nephrotic syndrome. Now let's talk a little bit more about hypovolemic hyponatremia. Here, the extracellular fluid volume is decreased, and one can assess this by physical exam findings such as decrease in orthostatic blood pressure, dry mucous membrane and loss of skin turgor, and labs such as increased BUN and creatinine ratio. Usually this kind of hyponatremia improves with IV fluid challenge with normal saline. The most common causes of hypovolemic hyponatremia are gastrointestinal loss from protracted vomiting or diarrhea, diuretic therapy with thiazides, cerebral salt wasting or secondary from head injury or subarachnoid hemorrhage. Mineralocorticoid deficiency could be from primary adrenal insufficiency. Euvolemic hyponatremia, the extracellular fluid status is normal, which means their absence of signs of hypovolemia such as orthostatic drop in blood pressure, no decreased skin turgor, or no dry mucous membranes. And also there's no signs of hypervolemia such as subcutaneous edema or ascites. The most common causes of euvolemic hyponatremia are syndrome of inappropriate antidiuretic hormone. Now this remains a diagnosis of exclusion predominantly. The criteria for SIDH includes decreased effective serum osmolality less than 280 milliosmol per kg, inappropriate urinary concentration with urine osmolality greater than 100 milliosmol per kg, clinically patients are euvolemic, elevated urine sodium excretion greater than 20 millicoulombs per liter, and absence of other potential causes of euvolemic hyposmol or hyponatremic such as severe hypothyroidism, glucocorticoid deficiency. Now, other causes of euvolemic hyponatremia include psychogenic polydipsia, which is predominantly seen in patients with acute psychosis, secondary to increased free water intake. Severe hypothyroidism, which meets the criteria for mixed edema coma, can cause euvolemic hyponatremia. Glucocorticoid deficiency, which is predominantly due to cortisol deficiency with leading to suppressed arginine vasopressin. The 9 AM cortisol level will be below 10 micrograms per deciliter. Exercise associated hyponatremia, which is commonly seen in marathon runners who are overhydrated with excessive water ingestion, can also cause euvolemic hyponatremia. Some of the most common causes of SIDH include CNS disorders such as ischemic or hemorrhagic stroke, infectious conditions such as meningitis and encephalitis, inflammatory and demyelinating CNS conditions such as multiple sclerosis or Guillain-Barré syndrome, medications which include antidepressants such as tricyclic antidepressants, SSRIs, antipsychotic medications such as haloperidol, anti-epileptic medications such as carbamazepine, chemotherapy medications such as cyclophosphamide, and opioids, pulmonary disorders such as pneumonia, lung malignancy, and other miscellaneous conditions such as postoperative state, pain, HIV infection can all lead to SIDH. Coming to hypervolemic hyponatremia, clinically they have increased extracellular fluid status, which is noted on physical exams such as ascites or subcutaneous edema. The two most common causes of hypervolemic hyponatremia include congestive heart failure, where the non-osmotic release of arginine vasopressin is a dominant factor leading to water retention. There's also decreased renal blood flow, causing increased renin-angiotensin-aldosterone system activation, which can lead to hyponatremia. Cirrhosis, on the other hand, can cause portal hypertension and splanchnic vasodilatation, which can in turn cause non-osmotic release of arginine vasopressin, leading to increased water retention, which leads to hyponatremia. Before we get to the treatment of hyponatremia, one has to understand the pathophysiology of acute versus chronic hyponatremia. In acute hyponatremia, the cells swell with water due to osmotic gradient, moving water from the extracellular to intracellular, in turn causing brain edema. Now, in chronic hyponatremia, there's an adaptation process that occurs causing a shift of osmoles from intracellular to extracellular space, establishing a new osmotic equilibrium. Overly aggressive therapy with hypertonic saline in a patient with chronic hyponatremia can disrupt this adaptation and cause more water movement out of the cells, resulting in osmotic demyelination. So if a patient does have severe hyponatremia, which is defined as less than 125 millicoulombs per liter with associated severe symptoms, one should go with emergent treatment of hyponatremia, which can be done in the form of 3% hypertonic saline infused at 1 to 2 ml per kg per hour or one can administer single intravenous bolus of 100 ml of 3% hypertonic saline over 15 to 20 minutes. One can repeat this bolus up to 2 times if the symptoms not resolve. We should be checking serum sodium every 4 hours while giving hypertonic saline. Once the serum sodium is greater than 125 millicrons per liter, or once the severe symptoms have resolved, one should switch to isotonic saline. If the sodium correction has occurred rapidly, then one should stop the hypertonic saline and use D5% dextrose at 3 ml per kg per hour, or 2 to 4 micrograms of desmopressin IV or subcutaneous every 8 hours. Now, acute symptomatic hyponatremia, there's an urgent correction of sodium by 4 to 6 millicrons per liter, but one should not exceed the correction by more than 10 to 12 millicrons per liter in a 24-hour period. In chronic hyponatremia, one should never exceed the correction of hyponatremia by more than 8 millicrons per liter in a 24-hour period to prevent osmotic demyelination. Now, coming to the treatment for hypovolemic hyponatremia that doesn't fall into the category of severe hyponatremia. In case of GI loss, the most common treatment is isotonic saline. If it's attributed from the diuretic therapy such as thiazide, they need to be discontinued and isotonic saline can be administered. Now, if the patient does have CNS symptoms, one can use hypertonic saline for a brief period. In case of cerebral salt wasting, this can be treated with isotonic saline in most of the cases. Hypertonic saline is only necessary in severe CNS symptoms. In case of mineralocorticoid deficiency, which is mostly a chronic phenomenon, volume repletion with isotonic saline initially, followed by stress dose of hydrocortisone and chronic use of fludrocortisone. Treatment for euvolemic hyponatremia. In case of SIADH, which is the most common cause, one should not use isotonic saline. If the hyponatremia is severe with CNS symptoms, one can use hypertonic saline for a brief period, but most of the cases can be corrected by fluid restriction to 800 to 1500 ml per day. Other medications that can be used for SIADH are the Vaptans, which we'll be talking about in a later part. Now, if it is from chronic alcohol use related to beer potamania, one has to stop drinking alcohol and probably start on medications to prevent chronic alcohol use. In case of glucocorticoid deficiency, the primary treatment would be glucocorticoid replacement. If hypothyroidism is the cause, the primary treatment would be thyroid hormone replacement. In psychogenic polydipsia, the treatment would be free water restriction and psychiatric therapy. If the hyponatremia is from exercise associated, then one should treat with isotonic saline, and sometimes they might require salt tablets. Treatment for hypervolemic hyponatremia. In case of heart failure and cirrhosis, the primary treatment would be both fluid and salt restriction along with loop diuretics. Now, Vaptans can be used in diuretic resistant cases only in case of heart failure. Now let's talk about Vaptans, which are also called vasopressin antagonist. The two most commonly used Vaptans are tolvaptan, which is also called Samska, and conivaptan, which is called Vaprisol. Now, tolvaptan is orally administered in a dose of 15 to 60 milligrams once daily, and the conivaptan is administered intravenously in a dose of 20 to 40 milligrams per day. Vasopressin receptor antagonist, aka Vaptans, are used in patients with sodium levels less than 125 millicrons per liter. They're not used for severe symptomatic hyponatremia. Fluid restriction should not be used concomitantly while on Vaptans. Now, recommendations for the use of Vaptans in the treatment of hyponatremia by expert panel. Vaptans is not a treatment option for hypovolemic hyponatremia. Vaptans are a treatment option for asymptomatic euvolemic hyponatremia. Vaptan is not a treatment option for euvolemic hyponatremia with moderate to severe CNS symptoms. Vaptans is a treatment option for asymptomatic hypervolemic hyponatremic patients from heart failure. They're not to be used in people with cirrhosis. Vaptans is not a treatment option for people with moderate to severe CNS symptoms with hypervolemic hyponatremia. Now let's talk about hypernatremia, which is defined as sodium level greater than 145 millicrons per liter. It is mostly associated with hyperosmolar state, which means the osmolality will be more than 295 milliosmol per kg. It is caused by net water loss or from sodium gain. Water loss can be due to pure water loss or hypotonic fluid loss. It can also result from fluid deprivation. Sodium gain is secondary to iatrogenic etiology. Diagnostic approach of hyponatremia depends on extracellular fluid status. In hypovolemic hyponatremia, the total body water is decreased more than the decrease of total body sodium. In euvolemic hyponatremia, the total body water decreases whereas the sodium content remains normal. In hypervolemic hyponatremia, the total body sodium increases more than the total body water. Most common symptoms of hyponatremia are related to CNS, which again could be altered mental status causing confusion, lethargy, and coma. Complications of hyponatremia can be seizures and permanent brain damage. Symptoms of hyponatremia are related to the acuity of hyponatremia and severity. Now, evaluation of hypernatremia based on the etiology. If it is from decreased free water intake, it's most commonly due to decreased thirst response, which occurs in older adults suffering from conditions such as depression. Patients are cognitively capable of obtaining free water yet fail to do so. Iatrogenic cause of decreased free water intake is seen in people who are hospitalized and sedated, intubated, or not allowed to drink. It is also seen in long-term care facility or nursing home patients who may not receive adequate amount of free water. Increased free water loss can be due to various causes. It can be from diuretics, from excessive sweating, environmental exposure to prolonged heat, diabetes insipidus, which could be central or nephrogenic etiology. Increased sodium intake predominantly is iatrogenic, and it could be secondary from increased sodium bicarbonate tablet or hypertonic saline administration. Treatment for hyponatremia depends on the etiology. If it is from decreased free water intake, one should encourage increased free water intake by mouth, or it can be given by IV fluids in the form of 5% dextrose in water. If it is due to diuretics, one should stop the diuretics. If it is from increased free water loss, either from profuse sweating or excessive exposure to heat, one can give free fluids by mouth or by intravenous route. Central diabetes insipidus usually doesn't require much in form of treatment, but nephrogenic diabetes insipidus, which is mostly caused from medications, can be corrected by stopping those medications. Now, water deprivation test can confirm the diagnosis of diabetes insipidus, and desmopressin stimulation test can determine if it's central versus nephrogenic diabetes insipidus. In terms of hyponatremia from increased sodium intake, the treatment most likely just involves stopping the cause of it, which could be either salt tablets or hypertonic saline. Now, correction of hyponatremia is very important. If it's an acute symptomatic hyponatremia, one should not lower sodium by more than 10 to 12 milliequivalents per liter in a 24-hour period. In a chronic asymptomatic hyponatremia, one should be more careful and not lower the sodium by more than 8 milliequivalents per liter in a 24-hour period. Rapid correction of hyponatremia can cause complications such as brain edema. References for my talk include